TAVI outcomes. Here are my disclosures. So what we need to optimize for TAVI in 2024 are these 5 things. Minimize PVL parabolically, optimize valve frame expansion, minimize pacemaker risk, avoid severe prosthesis patient mismatch or PPM, and facilitate lifetime management, mainly coronary access and redo TAVR. And to do that, you need commissural alignment and CT simulation. Here are the current generation TAVR devices. Some of the ones you see here, such as SAPIEN 3 Ultra or Resilia, and Evolut FX and Navitor are now available in the United States. All these have external sealing mechanisms to minimize perivalvular leak. However, we still need to post-dilate when necessary to reduce the leak, particularly if it's only mild or moderate, and we should aim for trivial or none, based on the anatomy that we deal with. The other reason to post-dilate would be to optimize valve frame expansion. In balloon expandable valve that we have seen recoil during expansion, such as the Resilia, or self-expanding valve looking at the aerial caudal projection and the short axis of the annulus, such that you try to achieve a more circular geometry whenever possible. Here's the seminal paper from Circulation showing that a significant percentage of TAVI devices that we put in actually are underexpanded, and underexpansion is associated with halt or hypoattenuated leaflet thickening. So you can see that example here. This is an underexpanded 26 SAPIEN 3 despite nominal inflation, and you can see the area of the native annulus on 451 millimeters square, and when you deploy a 26 millimeter valve, you actually end up being more like a 23 millimeter across the entire frame geometry. And we actually have published 2 papers on this topic, such that we do not need to oversize much at all now with balloon expandable valve. In fact, if you undersize beyond the manufacturer recommendations, provided the mean diameter is 1 or 2 millimeters just above the nominal dimension, you actually, because of the native leaflet occupying space, achieve more complete expansion as we show in the CT without compromising hemodynamics, including mean gradient. At the same time, you can see that here on the top right panel, by downsizing the valve, you actually would facilitate redo TAVR, and you can see that here there's significant difference even at 80-20 deployment depth. The other thing we need to look at is pacemaker risk. Obviously, nowadays we try to implant high, and we use the cuss overlap view for self-expanding valve, and maybe even balloon expandable valve as well during deployment. But keep in mind that high deployment will reduce coronary access and reduce TAVR feasibility. This is the first paper that described the cuss overlap view published by our group on simplifying self-expanding valve deployment. And since then, as we know, that it has indeed reduced pacemaker rate. The other advantage of using this view is that you can aim to achieve commissural alignment in a variety of self-expanding devices, including Evolut and Accurate Neo. In fact, balloon expandable valve is also being deployed now in aerial caudal projection or cuss overlap view in certain centers, including this paper from Cleveland Clinic showing a reduced reduction in pacemaker rate. And so this is very important to consider now in the current TAVR era. Severe PPM after TAVR we now know is associated with increased mortality. And you can see the seminal paper from the left by Howie Herman and Longevity Registry showing 1 year increased mortality to a meta-analysis in JACC imaging showing the same pattern across several studies. Now this New England Journal paper just published on the SMART trial looking at self-expanding supraannular Evolut valve versus the SAPIEN 3 valve with Ultra in small annuli, showing that indeed with a supraannular self-expanding valve has some benefits. And in this particular study, balloon expandable valve did have higher gradient, lower EOA, more paraprosthetic valve dysfunction, and more moderate severe PPM versus the Evolut platform. Now, lifetime management after TAVR is increasingly important, and specifically coronary access and reduced TAVR are now hot topics in most meetings. And the reason being CAD after TAVR, it's really prevalent. You can see that here, even in intermediate risk patients, over 60% of them have coronary artery disease. And so really depends on the coronary angiography and PCI, depending on the device type and anatomy of the aortic root. And the reason why it can be challenging is that most operators out there are not familiar with TAVI at all. And so the number of barriers limiting re-access, not just the native aortic valve leaflets, the valve frame, and of course, the valve commissure if you have misalignment. So really important to understand the aortic root anatomy and the TAVR device. The shorter frame valves will be more relevant in terms of reduced TAVR than coronary access. But the taller frame valves, most of them are self-expanding valve, will be relevant in both coronary access and reduced TAVR, particularly in supraannular devices. This JAB state-of-the-art review that we published outlines some anatomic and device procedural factors involved in coronary access. And you can see that here, commissure alignment is now extremely important because not just affect coronary access in taller THV, but also reduces coronary obstruction risk in TAVI SAF, increases the likelihood of redo TAVR. There's now early evidence of impact on durability and hemodynamics. Certainly, leaflet modification would not be feasible, such as basilica if the commissure pulse facing the coronary. And of course, all valve manufacturers now are focused on this topic, so clearly everyone's seeing this as critical to the lifetime management. And we have recently published a Aligned TAVR Consortium state-of-the-art review in Japanese dimension, talking about this topic, defining the degree of misalignment to standardize the nomenclature, and talk about some of the coronary eccentricities and some of the other techniques as well to optimize alignment. For those of you who don't know what alignment is, you can see that here on the bottom, on the left side, if you have a commissure alignment with the native commissures, you really have a lot more open cells available to access the coronary, versus the right side, if you have a commissure post facing the coronary, you really have to go either side of the post to access. So for the Evolut platform, we now know that you can insert the flush port at 3 o'clock and then get the height marker facing you directly in the center front. And when you release the valve, as long as one of the head marker, the C-tab rather, faces the right side of the screen as you see here, then you should have good commissure alignment. With the accurate Neo2, it's a bit more complex. You start with the flush port at 6 o'clock, and a 3-cusp view, you see where your projections are on your 3 paddles. And if you see that the 3 paddles, one of them may be here 111, you might need to actually go to the cusp overlap view and make sure that one of the tab is facing the right side of the screen, like what we described in Evolut. If not, then you should try to rotate clockwise or counterclockwise to achieve that. In fact, Giuseppe Tarantini's paper show that if you have commissure alignment with these tall self-expanding valve, you can see that selective coronary angiography is improved compared to if it's misaligned. Now, commissure alignment is also important for TAVI SAF because you can see this here on the panel E and G that even if you have leaflet modification, if you have a commissure post facing the split portion of the leaflet, you still have coronary obstruction risk. So clearly this is important for TAVI SAF even with leaflet modification situation. And you can see that if you have 2 valves in place after redo TAVR, the commissure alignment of the second valve, if the first one is short one, the second one being tall would be important, and vice versa. If the first valve is a tall valve, then the commissure alignment would matter first, especially if the second valve is a short valve or particularly a tall valve. The problem with having the tall and tall combination of redo TAVR is that these 2 valves don't align in the cells. So really you reduce the cell opening significantly after the second valve goes in. In fact, it might not even be feasible to perform coronary access afterwards. Now, what about lifetime management? You see that here, this nice European Heart Journal review shows the different aspects of sequencing of TAVI versus SAVR. And you can see that here, if you have a TAVR failure, the number of mechanisms involved, and depending on the mechanism, your management strategy would be quite different. either will be usually redo TAVR or TAVR Extra. And there are now new vocabularies to learn to be able to figure out some of the nuances involved. But thankfully, we have sizing charts now, and Minibaba just launched its Redo TAV app. You can see that here on the right side of the screen that walks you through all the workflow of how to reevaluate patients with failed TAVR for Redo TAV feasibility. I've also have a YouTube channel that shows you how to perform CT workup, and they'll be updated soon. And you can see that here, these are some of the examples of the Redo TAVR of different combinations. Now, CT simulation before the in-depth TAVR may be important because you can see what is the likelihood of redo TAVR. You can see this paper that's published in Circular Intervention by a group showing that if you have a higher implant, your likelihood of redo TAVR of unlikely will be going up, so it's less going to be, will be less feasible. At the same time, it's going to be the same in terms of coronary access as well after 2 valves being placed. So in summary, achieving optimal TAVI outcomes is now paramount as TAVI expands to younger and low-risk patients. Besides minimizing PVL and pacemaker risk, optimizing the index TAVR procedure will be important to confer durability. You want to avoid severe PPM and also aim for commercial alignment whenever possible. And lifetime management feasibility must be evaluated in addition to the above factors, particularly in younger patients where the patient will likely outlive the index TAV. I'd like to thank you very much for your attention.
All right, well, you know, Gilbert does a great job presenting a lot of things and also creating very complex slides. We're going to go to the complex scenarios right after, but first let's have some reflections from the panel about what we heard. And my first reflection is that all these things seem to be attractive. They seem to make sense, but it's so complex to figure out the slides. Are we really practicing them even sort of blindly while we're doing the procedure? Because, you know, all these alignments work well in the simulation perhaps, but while you are in the procedure, you look at the hat maybe or look at something else, and, you know, even the coronaries are not exactly aligned the same way in every patient. Perhaps we start from our surgeon that has much more experience with, you know, the patient variability of coronary, let's say, ostia location, and you know, how could we make some practical sense of all of those situations that we just heard?
Well, the good news is I can always align my valves. I never miss the commissures, ever. Sometimes the bicuspid valves are 180, and then you have to favor the left because we always want to make sure that we can get back to the left. But you know, for the Evolut FX, we can pretty much always align that. We'll get about 90% alignment. It's got the dots on it now. The newer Navitor is going to be called the Vision. It has dots. A little harder to line up. The Accurate we can line up. It's a little harder to see because you look for the free cell. I can't line up with a balloon expandable yet, but the next generation is supposed to. And I think the closer you get to replicating what we do as surgeons, the better off you'll be. I think that having your sinuses open not only gives you access to coronaries, but there's a reason you have sinuses, and you need those open, and you really don't want to post in front of it. So Gilbert's done a lot of work showing us how to do this, and we teach all our fellows on all these self-expanding valves to line up the commissures.
I mean, coronary access is becoming a very, very important factor because we're moving to younger patients. And in the older population, perhaps AS protects in some ways or has protected them from development of CAD, or the disease is not aligned all the time, but the earlier you relieve the aortic stenosis, the more exposed you are to risks of CAD later. So it's an important factor to be considered. Perhaps Dr. Kilic and then Dr. Damascus.
For the commissural alignment, I want to make some comments, especially about the balloon expandable technology, with the novel balloon expandable technology. MyVol octacore, for example, creates a clockwise octaline method. Especially, you had to look at to do CT images before the procedure. It's very important to find the geometric nodule of the valve salvationis and the exit point of the right coronary artery, and make a clock angle, and then according to that clock angle, you crimp the valve, balloon expandable valve, of the commissural post, at least one of the commissural posts, to the exit of the right coronary artery. So this shows that over 90% commissural alignment for the balloon expandable valve. As Dr. Arden underlines, for the self-expandable technology, it's very important to look at to do procedural where the capsule head marker, center front or center back, especially in the cusp overlap views. So these all are very important for the future coronary access. But my question may be, how many of patients, older patients, after TAVI, do you routinely use coronary angiography, or how many PCI have you ever been performed for older patients?
No, not that much. I mean, of course, I follow the practice of if you need to fix a coronary, I like to do it when it's easy, before the TAVI. I don't understand quite frankly, I don't understand even the study designs that pushing coronary procedures after TAVI, because you just take something that's quite simple into something that just, even if it goes well and smoothly, it's definitely more complicated. So why muck around, so to speak? Let's go to Dr. Damascus and then Dr. Tsolakis for their comments. And anybody here, or by the way, anybody who welcome our internet attendees, you can send a note in the chat. I have it right in front of us here, and we're going to ask this question as you view the session through the web. Dr. Damascus.
Just want to say that deployment is very important even in older patients, because you never know how long they will be around and if they will need a second TAVI at some point. So we have to do our best to follow certain benchmarks and do the best deployment we can in the room. Of course, can we say that we can reproduce deployment 100% every time? No. We all have to work and get better at that. But we have to do our best in any case. Also, just to bring into attention, there are what I call hacks, like the basilica procedure. We have to take a good look at those kind of procedures and ideas, because they might give us some slack on a not 100% certain deployment, and give us the ability to make small mistakes in the room that we will not pay in the future.
Great.
I would like to say something else. The main problem with the coronary ostea is the same problem for all the patients, and you will find these problems as long as you are doing younger patients. The height of the coronary ostea is the main problem, first of all. Second is the alignment of the commissures. As a surgeon, I know very well that there is not a circle annulus in every patient. There are so many differences between the patients that cannot be able to know before the operation, before any TAVI, the coronary alignment, the annulus alignment, and the leaflets. So the problem remains, if you're doing younger patients, you will see more problems, as we saw there's problems in open heart surgery. But the future is that if you are doing also younger patients, you will see that sure you're going to see also coronary artery disease. And the second operation will be much, much more difficult than the first operation TAVI in these patients. This is my opinion.
Yeah, no question. And let's come back to our heart surgeon. I want to ask a very specific question, because it's coming up. There's a wave of patient-driven preference to earlier ages. How facile is our surgical community into TAVI explant and reoperation? Where are we with that? You know, I'm not sure we're anywhere, quite frankly. And I mean, I don't know what to say except that it's just becoming a reality with all the waves of these TAVI valves that, you know, some of them going to treat with valve-in-valve, but some maybe not. And, you know, I think, does it vary according to what kind of valve you have before? Let's say a core valve or a balloon expandable, a taller or a shorter valve?
Yeah, well, clearly the taller valves, all the self-expanding taller valves are going to have a harder time having a valve-in-valve. And we usually put a balloon expandable inside a self-expanding, and when a balloon expandable fails, we put a self-expanding inside a balloon expandable. But 30 to 50% aren't going to be able to have a TAVR and TAVR, and they're going to need it explanted. And you know, Gilbert did the explant TAVR registry and showed that it had double the mortality of just doing a redo aortic valve. The problem was the mean number of explants done by surgeons was 1. Most people have not done, whereas centers, I mean, I haven't done one since Wednesday. That was the last one I did this week. Because now they're coming in and the smaller centers don't see them, and so we're doing one almost every week now. Now in the U.S. we did over 100,000 TAVRs in 2023, and about half the people under 65 are getting TAVR. So for my younger generation surgeons, this will be the fastest growing operation they need to learn. And I have, these are all done by my fellows because I'm really interested in how we can then teach this to our fellows. We're going to have to learn to do this and learn it better. But I do tell younger patients when they come in asking for TAVR, I can look at your CT and I can usually predict how likely we're able to do a second TAVR. You have low coronaries, small sinuses, you're going to get your TAVR explanted. If you have a really tiny annulus, you're going to get your TAVR explanted. And I tell them up front that this is not just it's not just like getting a first-time aortic valve. It has double the mortality. And I think the reason we're moving to younger people in the U.S. is we have some non-functional heart teams where surgeons aren't really playing a role in actually telling the patients that. And that's a problem.
Yeah, we'll come back to that last one after our last speaker of the session. TAVI in